Coming in with a hot take this week, I loved working in a skilled nursing facility. Skilled nursing facilities are one of the highest paid settings for occupational therapy professionals, and about 1/5 of us work in one. But they can also have a bad rap because of the high productivity standards. In today's intro to SNF OT course, we will walk through the common challenges and immense opportunities of working in a skilled nursing facility. We'll cover the specific things you need to know, from payment models to common assessments. And we'll paint a picture of how you as an OT professional can really be a driver of culture and care in this important setting. We'll be joined today by Trent Brown, MOT, OTRL, ATP, CGCP, CFPS, BCG. Trent is a practicing occupational therapist who is also part of the Department of Health and Human Services as an assistant office director, with a focus on developing and operating quality improvement programs, particularly in skilled nursing facilities. So let's dive in. Welcome to the OT Potential Podcast. Before we begin, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. After listening, you can log into the club to take a 5-question quiz, and we will generate a certificate for your time today. Okay, here we go. I am so thankful today to be joined by Trent Brown. I have been looking for a speaker related to SNF OT for a long time, and I am so thankful that I found Trent. Trent Brown is a practicing occupational therapist and a holder of a board certification in gerontology from the AOTA. Trent also holds certification as an assistive technology professional from RESNA, an advanced certification as a fall prevention specialist and geriatric care professional from Evergreen National Certifications. He completed his undergraduate and graduate work at the University of Utah. Trent is employed by the Department of Health and Human Services as an assistant office director, with a focus on developing and operating quality improvement programs. Trent has worked closely with his state association in establishing state law, including co-authoring SB 131 and HB 188 to advance OT practice in Utah. Trent has over 20 years of clinical experience in skilled nursing, transitional care, acute inpatient rehab, and home health settings. He has provided continuing education courses to tens of thousands of clinicians throughout the country. Trent is a tenured clinician and lecturer on a myriad of topics, including core stability, documentation, aging, functional mobility and gait, ethics, postural alignment, and fall reduction. Trent is also the peer reviewer for the Journal of Topics in Geriatric Rehabilitation and a guest reviewer for the American Journal of Occupational Therapy. So without further ado, we will patch Trent into our live studio. Welcome, Trent. It's great to have you today.
Thanks so much for having me, sir. When you reached out to me a little while ago, I'd been following you in podcasts and other forums for quite some time, and I had a little bit of, celebrity pause. So thanks so much for having me on. It's a privilege.
Oh, well, this conversation is such a long time coming because I loved working in a skilled nursing facility back in the day. I've then transitioned to continuing education, and I have been on the hunt for someone who loves SNFs as much as I do and loves talking about them. So I was so happy to come across you and your work. We have so much to talk about today, but before we get into the details of what SNF work entails, I would just love to hear a little bit about your story, how you got interested in this practice area. I also want to hear just a little bit about your job and what you do as far as quality improvement and how you got there.
Okay, I'd love to do that. Yeah. So I had just graduated OT school. I had just finished 12 weeks into a school system. And so I really wanted to work in a school system. So I applied for a job within our local district, or one of our local districts. They had 2 openings, and 3 of us from my same graduating class applied. The other 2 of my colleagues got the job. I didn't.
Oh,
So I said, okay, well, I'll go work up at the SNF. They were paying, kind of an exorbitant amount for just trying to desperately find an OT. So I said, hey, I'll go do some PRN work up there. I was working 30-ish hours a week or whatever. And so I'd kind of go up and not really knowing exactly what I was going to do. And my first patient comes along, right? And it's this guy wearing this World War II hat and starts to tell me his story about where he came from and serving in the war and how he went off and eloped with his wife when they were 17 before, just this kind of cool all-American story. And I just sat there for like an hour ago and this guy's awesome. How fun. Like, I don't even know if he did any therapy. I can't remember. So just this great story, cool guy, took him back to his room, grabbed this lady, bring her down to the gym. And suddenly she starts to tell me kind of a similar type of story, but on the other end, yeah, my husband served in World War II. And I just started to kind of fall in love with these people in this population. I'm like, these people deserve every good thing that's coming to them. And just, kind of the laid back environment and working with my OTAs who I was the only OT. I had a bunch of OTAs to kind of tell. It was funny because I came in and said, I'll do these evaluations and here's how I'm going to do things. All right. No, Trent, here's how you do it. We've been here for 10 years. And so it was kind of fun just being humbled and kind of learning that aspect. I liked the team environment that we had with our PTs and just with that population, how much I loved them and just kind of grew to that. And at the same time, as a patient would pass away, it was like, they were 85. They've lived a great life. This is probably a good thing. I'm glad that I was able to help them have a good end of life. It was very, very satisfying to me versus sometimes in other environments like in peds where it's so sad when these kiddos get cancer. Like I'm working hard with them, but I don't know what the future entails and how difficult that is versus these people where you meet their family, their grandkids, and you see this legacy that they've developed. And so for me, I just kind of fell in love with that population and really kind of, I did a whole bunch of other PRN, outpatient, SNF, acute, rehab. I did a whole bunch of other things, but SNF was kind of my primary care. And so that was kind of my baby. And then to the second part of your question, well, what I currently do. So about 8 years ago or so, I saw this posting from the Department of Health at the time. Now it's Health and Human Services about a position looking at kind of quality improvement with nursing facilities. They wanted maybe more of a clinical background. So I was like, oh, that sounds interesting. So when I interviewed and kind of learned about what they were doing, they offered me the position. It was way, way less than what I was making at the point. I said, I can't take a $40,000 a year pay cut to do this. And so I kind of went back and forth with them. Eventually we settled on it, but kind of what convinced me to take kind of a different direction was, at the time I was the director of rehab, I was overseeing a bunch of different therapists. I thought this was cool because I can impact these therapists that can then impact a couple hundred patients, with my regional position. But then I saw the number of people I could potentially impact through investing into better quality care. And in Utah, where I currently work and where I was being proposed this job opportunity, we had about 10,000 nursing home beds. It's like, if I can do something, through law and through policy and other things to impact 10,000 nursing home residents, man, that is awesome. Maybe I'm willing to take a little bit of a pay cut at this point, potentially work my way back up into a different area. And so that's kind of what led me to that is how could I impact not just my direct staff or just my patients, but man, globally, about 10,000 licensed nursing home beds amongst some other policy in some other areas. But to me, it's like, how can you not take that? We're always striving for advocacy and to push the boundaries and seeing it's like, this is my moment, right? So that's kind of where I came upon that job. And so really, I oversee, we have a big influx of cash. We're in the state of Utah. And many other states do the same thing. We pay Medicare rates for Medicaid patients. That extra money, we want to ensure that they're doing certain quality things. Don't do those things, they don't have access to that extra, what we call gap payment. And then we also have several $1 million on the side where it's a great program. We have about, it's about $6.5 million where facilities can invest or purchase items that are quality of life, not care issues like EMR and things like that. But go out and purchase a bunch of brand new 65-inch flat screen TVs for all your patients and we'll pay for it. So each facility is kind of given a limit right around $70,000 to $80,000 based on the size of the facility. And we're like, go purchase quality of life items and we'll pay for it. So that's kind of fun just to see these items come in and ice machines and soda machines and all these things that maybe aren't that healthy, but it just, end of life. It's like, let them drink as much Coke as they want and we'll pay for it. So it's kind of fun that way.
Yeah. Oh, I could talk quality improvement all day, every day. I love it. I love that is your work, your job now. It reminds me so much of actually being in a skilled nursing facility. When I think back on my work, I think of that as the place where I got the most like facility-wide changes off the ground. I felt like I didn't have that same capacity in acute care or even at the outpatient facility because it was still part of a hospital system. But there was something that I loved about skilled nursing because of the team, of the ability to make changes within the facility. Just felt like as a therapist, I could get more done. My question for you is thinking about the different adult rehab places that OTs work, acute care, outpatient. What do you see as setting skilled nursing apart? Like if someone's worked in one of those other settings, what kind of mindset shift do you need to take as you step into a skilled nursing facility? It really feels so different to me than those other settings, even though the treatments are actually pretty similar.
Yeah. And I think that's the home run message right there is a lot of people come to a SNF and say, okay, well, this is going to be laid back. This is going to be simple. I have to kind of grade everything down and make it so simple and light. I can't push these patients. They're fragile. They're frail and all these different things. And although there might be some type of physical truth to that, right? To your point, Sarah, you don't necessarily have to change your therapeutic intervention, your skill set, your tools. Honestly, in my opinion, the biggest mindset shift that going from some type of, more traditional setting to now more of a SNF it's kind of more of that business model, right? So yeah, my treatment doesn't have to change necessarily. I don't have to, shift how I do things all the time per se, but it's just going to be a different environment where I might bill differently. I have to document a little bit differently. I might have different expectations and some of those types of things. And so I just think that's a big thing is bring all the best skills and tools that you have. Yeah, instead of working with maybe a 60-year-old person at outpatient clinic on hands, you might still be working on hands with someone who's 81. You might have to grade that down a little bit, but it's still going to be the same theory, the same skill set, the same tools of things that you would normally do with a patient. So none of that should change. Our ability to grade modify that might have to change a little bit, but please don't change anything. It's funny because when I go around and teach, I'll show some really high level activities that I do with my patients. And they're like, you don't do that with your patient. Then I show pictures and videos of me doing this with my 89-year-olds. And I say, I look at my older patients as athletes, just as I would in any other type of outpatient setting. But instead of doing bench press and deep squat, they're pushing to get their clothes on or to open a drawer or to, do a deep squat onto a toilet. That's their sport. I'm not, I'm not bench pressing 200 pounds, but I have to be able to lift an 8-gallon thing of milk or a 4-gallon thing of milk, so it's still very athletic. It's still very physical. It's still very cognitive and visual and all those other things. It's just for a different set of patients. So hopefully that answers that question of, yeah, there could be different business models, some productivity, some things you may not have seen before, but man, you shouldn't have to go into some complete paradigm shift as far as treatment.
Mm. I just remember saying to myself all the time, like, I may not be able to change this person's trajectory of their disease course, but I can absolutely improve their quality of life.
Totally.
And I just remember thinking about quality of life like all the time when I was in a SNF, which is part of why I loved it because I love thinking about quality of life.
Absolutely. And hopefully as well as our patients are getting a little bit better or improving in certain areas, it helps the culture of the skilled nursing facility as well. If I can make my CNA and my nurses and my rec therapist life a little bit easier through suggestions or getting my patient a little bit more functional, it makes everyone's lives easier and reduces burnout and then we become part of the team.
Mm-hmm. So if someone is listening to this, they've never worked in a skilled nursing facility, they maybe even just got hired at one, they're going to work in a week or so. How do you set yourself up for success, especially thinking of it as a setting where there are high productivity expectations? I had one job where I spent part of my day in acute care, part of my day in an outpatient, and part of my day in a SNF. And definitely in that SNF, they were paying the most attention to my productivity. Like it just stands out as a high productivity setting. How do you prep for that?
Yeah, that's, again, another fantastic question. So it's just kind of coming in with that mindset of, I went from a place where maybe I wasn't, controlled as much in that area or this area, but like all of the facilities, SNFs kind of have their pros and their cons. When I do home health as well, sometimes the con is, well, yeah, regardless of how long I stayed, I get paid the same amount. Sometimes I'm with patients for 2 hours and the pay sucks. Sometimes I'm with them for 40 minutes because that's what they need and the pay is great, right? So we always kind of have these different things. And so I think skilled nursing facilities, as you mentioned, Sarah, are always about productivity because it's a business that's going to have to make money. That's what's trying to pay attention is how efficient am I during the time that I'm there. So productivity on its own isn't necessarily a bad thing. Sometimes it's kind of how it's communicated and all those types of things. And so, it's often kind of that 85 to 92% productivity. Sometimes it's a little bit less for an OT or a PT because they have evaluation time, more documentation, those types of things, right? So I think as you're transitioning to a SNF, just understanding for the particular company that you're going to work for, what is the productivity expectation? Okay. If it's kind of that 90s ballpark, 85 to 90, that's pretty standard. So I've heard a lot of OTs or, PTs even say, oh, I'm not going to work there. They're at 91.5%. Well, yeah, don't go work there. That's relatively standard per se. So yeah, just kind of understanding what that expectation is. And just having frank conversations with the director of rehab or even other therapists in the clinic and saying, okay, you've got this expectation. What's your caseload? Right? So if I'm seeing 20 patients for 20 minutes each, that's hardly that productivity because you've got so much documentation, seeing, all these patients for just a short amount of time versus, oh no, we see our patients for 45 minutes to an hour. You'll only be seeing 6 to 7 patients a day. Oh, that's much more feasible. That actually makes sense. If they buy technology, if you have a computer that they give you, you've got your own laptop. So I'm not necessarily a huge fan of point of care documentation. But hey, while my patient's taking a quick rest break or while I'm talking to them about next steps, totally open that computer and, be documenting at that same time. So if the facility or company is willing to set you up for success, if they're fair with their expectations, they're upfront with those types of things. Yeah, just kind of understanding that that's part of a skilled nursing facility. Just like, I mentioned before, every other type of setting has its own expectations. This is just kind of one of those things. We can't always control that. That's sometimes a company expectation or whatever. But as long as you come in with that mindset and that expectation. Also, if you're a new grad or it's been a while since maybe you've been practicing, can you have a mentor? Is there another OT that's going to kind of be by your side? Or is it just kind of you by yourself and they're doing evals and then you put all the care over onto OTAs or, so kind of be aware of those types of things. So, I mentioned my first setting where I worked, I was the only OT. I didn't know that I was brand new grad. I had no idea what I was doing. It's like, give me a job and pay a bunch of money and off I go. Thankfully, again, I had those 2 amazing OTAs who kind of taught me everything that I knew, for the first couple of years. But they worked with me and said, we have a PRN OT that's going to come in the mornings and spend the first 2 or 3 hours a day with you. Talk with them, pick their brain, do all, so they were willing to do that with me because I was a new grad. So kudos to that company for doing that. But whether you have a mentor, can you get a copy of what their documentation looks like, right, prior to even starting, just so you kind of have a heads up on those things. So it's not just, coming in with a complete blindfold. But yeah, if you could start to kind of see their EMR and their software and what that looks like. And again, do I have my own computer? Do I have to share this with other, things? What are my expectations as far as breaks? Just go and ask those fair questions, ask those bold questions so that you can go in there with more of an open mind and you can control what you can control and know what you can't control.
Mm-hmm. In each new setting I was in, I would ask for examples of documentation and I would just walk around it with that on my clipboard. So I kind of knew what to ask and kind of, served as that initial guide. I so distinctly remember talking to my director of rehab and he showed me his spreadsheet, which at the time was reg levels. And this was months into working. And I was like, oh, this setting finally makes sense because now I understand the payment models behind it. I am out of date because reg models are gone. Can you tell us about the payment models that currently is driving skilled nursing facilities, what we need to know about it, what questions we maybe need to ask our facility related to it? Yeah, what do I need to know there?
Yeah, absolutely. And again, just a fantastic question. And we could spend 4 or 5 hours on the patient-driven payment model, or what we call PDPM, that switched over in October 1st of 2019 and what that looks like. And yeah, it was funny. I was with you again, a brand new grad. It's like they keep talking about these RUGs levels. And for me as an OTO, when I hear RUG, it's like that's what we remove from a patient's home, right? Yes. And they kind of showed me this model. But like you, it probably wasn't until 4 or 5 years in this experience that I started to kind of figure out, here's what this means as far as, oh, if I see a patient this long, they get this much money, so sometimes I'd see a patient for 65 or 66 minutes. They get mad at me. I'm like, why are you so stressed out over 6 minutes? And then I saw the pay difference. It's like, okay, I get that now. Yeah. So the patient driven payment model, which came about, 5, 6 years ago, I can't believe it's been that long. But this has less of an emphasis on therapy, and which in some ways is unfortunate, but in some ways is good. And kind of more of an emphasis on the overall needs of the patient. So beforehand, with the old drug model, basically it was all about therapy. If they had this much therapy, you got this much money. If they had this much therapy, they got this much money. PDPM takes much more into account nursing needs. It takes into account their diagnosis. It takes into account the medications that they're on. So it kind of takes all these things and bundles them into kind of a payment, if you will. But in addition to that, typically they'll get paid more kind of for the first couple of days versus, week 2 or week 3, because the idea is they want to pay them a bunch of money up front, pay them less kind of down the scale to incentivize getting people out of nursing homes as soon as possible, especially for that short-term Medicare type of patient. So again, kind of the bad part of that is when this came to fruition, essentially a lot of therapists that were used to seeing patients for an hour plus, that got cut back down to maybe 35, 40 minutes, some even facilities even less than that. So that's just one thing to be aware of. When this first came about, CMS actually came out and said, hey, if we see therapy minutes being reduced, we're going to audit the heck out of these facilities that are doing that. Well, of course they didn't, right? So facilities started to kind of push that boundary and say, how little therapy do we provide, but still, maximize our revenue and things like that. So in some ways, that's kind of been bad. I think again, that paradigm shift, that pendulum's been swinging back a little bit more because, in the last 3 or 4 years, although they've been getting paid a little bit more money, as falls increase, hospital readmissions increase. It's like, okay, we still need therapy because besides just a business model, this is also a healthcare model. And so hopefully that return on investment is coming more about as well. So PDPM, back with the old drug levels, I think there were 18 different ways in which you could get paid or categories. With PDPM, there's like 80,000. So it's much more difficult to predict how much money patients are going to, make that facility. But again, I think overall it was a good move because it's a better recollection of what the patient needs and their frailty. But for us as therapists, sometimes I wish there was a little bit heavier weight to the therapy component of that. But at this point, that kind of is what it is. And obviously the nursing home industry likes it because they are getting paid a little bit more without having to have expensive therapists, or as many expensive therapists. So kind of an interesting thing there. Other payment models, of course, there's Medicaid, typically your long-term patients. Usually Medicaid residents, that when they're being seen for therapy, it's kind of more that Part B benefit they'll have. Mm-hmm. There's a cap to that, unfortunately. And so, once they've reached that cap, then they can no longer qualify for that. One other thing to think about, though, with this, most states do have Medicaid reimbursement. A lot of therapists, a lot of companies might not fully utilize that Medicaid reimbursement potential. So even if a Medicaid patient has maximized that Medicare B benefit, they can still bill their direct to Medicaid, benefit. It might not be quite as much as what Medicare pays. They might have some limitations to 20 visits a year per discipline or something like that. But a lot of people don't take advantage of that is just because a person's maximized their Medicare B benefit. If they need a little bit more therapy, they can look into Medicaid as a reimburser as well. And that's based on each state, obviously, with that. There's private pay. I had several patients who came in and said, hey, I was only in the hospital for a day or two. I didn't qualify for a SNF stay, but man, I just don't feel safe going home. We have plenty of money. Yeah, come on in. We'll do therapy and do everything else that we normally would. I love private pay patients because even though we would document, I didn't have to have the same, stringencies as I would have for CMS or some other type of insurance company. There's workers' comp. There's private insurance. So really all the other type of models that you might see in traditional healthcare exist in a skilled nursing facility. But primarily, it's going to kind of be Medicare A and B. That would probably be 90-95% of the patients that you would see there.
Such a different world where we really have to, or from what you're saying, it sounds like we might have to take a stronger advocacy role with our facility to really advocate for best practices, for evidence-based practice, for these stroke patients, more intensity is probably better. And back in the old rug levels, we just got that. Yep. They were problematic, but we easily got those minutes. It's funny to me because I'm like, there's even more research out now than there was back in rug level times about the importance of that intensity, but you might have to advocate for it more. So like in any setting, just get used to talking about money and advocating for your patients in that way.
Absolutely. And I think as people kind of start to understand the PDPM model, not that this is an OT or PT's primary role, but if you can, as I've started to learn about the PDPM model and where you can kind of, pro and con different things, it's like, okay, if you give me a little bit more time, it might not necessarily benefit you financially, But over here on the nursing side, right, if I've seen this patient do this, so if the nursing is looking more at these types of things, you can maximize dollars over there and let me still have my time. And it's kind of this happy world, right, that we can be in. So if you're educated to understand how PDPM works, you could definitely advocate and kind of go down those avenues. Like you said, sir, right, in one of the classes that I teach, I talk a lot about how much time that we need to spend with the patient before their brain starts changing and we can create new synapses, right? And they can get stronger and do different things. And usually it's about 6 weeks, 3 to 5 times a week. And typically it's 45 to 60 minutes during those 3 sessions a week. So it's not excessive time, but man, if we're not getting that time, then our long-term effect doesn't take an impact, especially with the older clientele. So yeah, I could sit here and do bicep curls all day long. It's not going to do anything unless I get a certain amount of time and repetitions and then integrate that into some type of function, right? There is no carryover. And so yeah, it's hard to take a research article and go to our administrator. So we have to be careful with those types of things, right? But yeah, if we can advocate otherwise, here's how this makes sense from a business perspective, then we can kind of get on that same page.
We already have some people in the comments who have not worked in a skilled nursing facility, are interested in it someday. Getting down to basics of just like, what are common assessments that you would recommend that as you're headed into a skilled nursing facility might be helpful to get oriented to off the bat and might become your go-tos. What about that assessment realm?
Yeah, fun question. I'm a big fan of assessments to a certain extent. Typically CMS, Medicare and Medicaid love assessments because it shows objective improvement, right? They went from a 4 to a 5. Great. It justifies our payment, all those types of things. Our companies love it because it's easy to put a 4 or a 5 on a piece of paper versus trying to explain mid versus mod versus max assist, et cetera. But first and foremost, the most important assessment, in my opinion, is your own eyes, your own hands-on, your own ability to actually, let's sit down and do an ADL routine with this patient. I often just put my patients on the edge of a mat and I take pictures or videos and I plot that into PowerPoint and draw different angles on that. I print it off and I give it to my patient and say, when you sit there for more than 3 minutes, here's how your posture starts to happen. Like, that's not me. There's no way. It's like, you sit at a 30-degree angle like this. You had no idea, did you? So it's just doing occupation, doing function, doing all those types of things, and just watching how your patient does that, documenting that, whatever type of dysfunction movement that they have or neurological issue that they have, or where their eyes go, their gaze patterns, all those things is so important that we often neglect because we have become so reliant on a piece of paper that tells us how to score this. So again, having said that, I cannot stress that enough that our best assessment is our own skill set. We went to school for a long time, learned all these things so that we can assess, evaluate these patients better than any other person can. Okay. Now, so outside of that, standardized assessments that I'd like to use. So typically I'm cheap and easy, and free, right? So those types of things I like. I don't like to download the really expensive ones where you get 100 sheets of those things. And so when I show you these things, you might say, Trent, those are pretty basic, but I try and look at the resource that I have. I also like things that are standardized with a lot of evidence behind them. So for example, I'm a big fan of the modified Barthel just in general. It's fast, it's reliable, it's so easy to do. Just do a quick ADL session with them, or even just kind of ask the CNA, hey, how they do with these things? Very easy to score. The functional assessment scale, kind of on the same level of that. I enjoy that one. I'm a big fan, especially in nursing home, of the functional reach test. This was developed back kind of in the mid 80s, and everyone thought this was the dumbest assessment. It does look dumb, but the more you do it and the more people have tried to kind of debunk it over time, this is an incredibly relevant, powerful tool that correlates very, very directly with how well someone will walk, how fast they'll walk, and how well they'll perform their ADLs. There's also a modified functional reach test for people who can't stand. So you can do this in seated, and you can do this in sagittal as well as from frontal plane. So it gives you a lot of tools with that. So it's a fantastic tool that takes you like literally 30 seconds to do. It's awesome. A lot of people use the tug. A lot of our PT colleagues use the tug. I prefer the tug manual and the tug cognitive. If you don't know what those are, go check them out. Because you do a normal tug, then you do the tug manual and you compare the two. Tug manual actually has them do something functional while they're doing the tug. So it kind of starts to get some cognition a little bit into it. It kind of gets some distraction there. It gets upper extremities involved a little bit more as well. So the tug manual is awesome if your patient has mobility. The trunk impairment scale and the PASS, PASSTC, I'm big on the core and the trunk. I teach an entire 2-day course on this. These are two of my go-tos because they're very functional, It looks at dressing. It looks at pelvic mobility. It kind of looks at cognition. It looks at a lot of different things with basically trunk and balance for this population. If your patient can walk a little bit, I love the 10-meter walk test. I know it's kind of more of a PT test, but there's a strong correlation between how well someone walks and how well they can dress and bathe. So there's a great scale, tons of research behind the 10-meter walk test where it says, oh, if they walk 0.8 meters per second, they can dress themselves. If they walk, 0.6, a little bit slower, guess what? They cannot cross the street and they're probably going to die within the next 2 to 3 years. Like there's a ton of just great research. So I like looking at walking speed because it's very functional on the other side of things. Then last but not least, I also like what I call the posture measurements. So like measuring forward head posture, looking at hyperkyphosis and kyphotic postures, those types of things, especially if they're spending a lot of time in a wheelchair. How bad is their posture? Is there something that we can do about it, either through rehab or through kind of modifying their environment so they're a little bit more comfortable? So I do a whole lot of, various posture measurements. There's a bunch of different ones online. You can go on and YouTube and those types of things. But, yeah, there's norms out there up to, high heavens with what's expected, for an unhealthy versus a healthy population, et cetera. So those are kind of my go-to. Again, I kind of have 8 or 9 that I primarily use. If I need to pull out the Lowenstein or the COP, all those things I could potentially do. But again, I want to be very, very quick. I want this to be easy. A lot of my patients who might not be able to answer these appropriately or properly through my observation, I can just go through a quick checklist and get a quick score for them.
Yep. Oh, that is such a great list. I love it. That's definitely one I would copy down and take into a skilled nursing facility with me. I'm kind of laughing at myself because I wrote down to ask you the question, what treatment sessions do you most enjoy? And I'm like, I don't think I would ask that in another setting, but I just have this I just enjoyed my treatment sessions in skilled nursing facility. You get to know the patients so well. I'm even thinking doing ADL routines in the hospital. It just feels so different. It does not feel like they're home at all, like they're going through so much. But by the time you get to skilled nursing facility, you're really seeing what their daily routine can look like. So even though I'm asking this question in a funny way and it's not about our personal enjoyment, what treatment sessions did you most enjoy?
Yeah, I agree with you. It's funny because you walk into most skilled nursing facilities and they do have a rehab space, usually a gym with, again, some equipment, some machines. Maybe it's not quite as extensive as what you might see in a lot of outpatient clinics where they might have, diathermy and all kinds of things. But most SNFs will have physical agent modalities. Most SNFs will have a space. Most SNFs will have treatment mats and some things like that. I'm a big fan of the high-low mats, so I can really modify those for what my patient needs specifically versus just a plinth that's kind of stuck into a static position. But really, I mean, honestly, when I think about my patient time and my treatments, anything, honestly, that's outside of the gym, I tend to enjoy those the most. Yeah, I get taking them down to the gym and getting them on a mat and kind of getting some muscles warmed up and getting them maybe standing and some assistance down there, maybe, a heat pack if that's appropriate or some other type of modality. But man, the times that we can utilize our facilities, right? That's usually when I have the most enjoyment. Hopefully I don't get in trouble, for saying this, but even when I take a patient outside and we're just sitting there, shooting the breeze, I kick my feet up on the fireplace or we're just chatting and I'm having the patient talk to me, sharing stories with me, and I'm having them move and change positions. So it's still skilled and billable, right? But it's just like, we're just chatting. I'm getting to know them and we kind of have that personal communication that I think so doesn't exist, especially in an acute care setting or, those types of things. And so just that one-on-one time where I look at them almost as a parent or look at them as a sibling or something like that, where this is a human being and I'm giving them my all as far as I got to get to know you and about you so that I can best address function and occupation with you. As much as I respect the fact that you want to get up and walk, yes, you want to toilet and all those types of things, what really is it that you need to do? And can I kind of find that inner sensitivity of that individual to help them come to that realization that I'm here as their friend to help them. I'm their advocate. I might be the only advocate sometimes, in this type of setting. But yeah, so anytime I can get them out of the gym into kind of an enjoyable environment where we're not sitting around machines and nurses asking questions and beepers going off and timers and rec therapists running around and the dietitian saying, hey, Trent, you're feeding that person who has congenital heart disease, now age 90, you're not now feeding them bacon, are you again? It's like, yeah, I'm feeding it. Yeah, they're 90. I'm going to let them, eat all the bacon, that they want. So just getting them in those places where it's you and them. they're not surrounded by a busy gym and
Mm-hmm.
everything that's going on. So those are usually my best sessions, and very, very skilled and hands-on. It makes me think outside the box because I can't just give them some therapy or weights or whatever. I'm actually having to build for the session. What can we do in those environments and walk around, getting them their vitamin D and talking about diet in their home and goals and things like that. So anything outside of a traditional setting, man, to me, that's a home run.
Mm-hmm. Oh, I just have the best memories of, we have like an outside standing garden. We would go out there. I would go to the dining room. I actually remember going to people's home as a home visit. And I remember going out and about in the community. Was that just because I was on this old payment model and I was in a small town? Or are there ways for us still to bill for activities like that?
Totally. Again, it kind of depends on the environment where you want to work at. But like if I take a patient home, right? So that was one of the goals that we had. As long as a patient lived within 5 or 10 miles of our facility, before they went home, we would always go do a home evaluation with them. And we would try and have a family member there. Usually I would kind of Google map their home just so I could kind of see the environment. If they have a wheelchair, all those. It was first time I ever did a Google map with a patient like 14 years ago. They were freaking out. They're like, "How did you get all this information?" I'm like, I went to Google. They're like, "What? They got my home there, street view, top. Yeah, I got everything, man. It looks like your pool hasn't been filled in 2 years. What's going on there? Don't fall in that thing. So." Even when I do some of my other, live courses and things like that, I actually show pictures and videos of my patients. I would take them up to Walmart. We had a Walmart literally across the street. Yeah, we'd go over there. We'd go grocery shopping. It's all the stuff that I'm doing in the gym to build up balance and neuromuscular re-education and vision. Is that working? Well, the best way to see that, let's put some nice, big, thick diabetic shoes on them with reduced proprioception and see how they do in a real life environment. Let's go do some shopping. Then we go back to our facility and actually make something, with this. So it's kind of a 2-day process, but yeah, we might be seeing less and less with that. I don't think it's because it's not doable. I think it's because it takes effort. It takes time. It takes planning. It takes buy-in from our facility. Maybe sometimes the turner's like, "Oh, you can't do that." It's like, I'd rather them, risk balance while I'm there holding them than do this in 2 weeks and end up with a broken hip and back into our facility for 6 weeks with a non-weight bearing hip, right? Like, look at the return on investment. Especially in the 15 years that I worked in a SNF, I was constantly outside in the community. I would take them to restaurants often, like the day before they go home. Kind of, hey, let's do a little fun goodbye, farewell, tour. There's all kinds of mobility there, sidestepping. How do they get around? Could they pull their own chair? All those billable things. But yeah, just so much fun. In my 15 years of doing that, never once did I have an issue. Now I'm not taking someone that I don't trust out there, right? But their whole goal is to go home. If I don't do that with them, then what am I even doing?
Mm-hmm.
To some extent. I can't do that in a gym where they have grab bars and parallel bars and 3 gait belts and 2 aids and everything else. Like, yeah, let's go out to IHOP or Denny's for an hour and let's kind of see how this goes, But yeah, never once did I ever have an issue with the fall or any type of risk or anything like that. So again, I'm not saying that's because I'm amazing. I do all these cool things. It's just because I think that's what OT is. That's what we are. If I just keep in the gym all day long, I'm a biomechanical therapist that's maybe not looking at the person and what they need and what they want.
Mm-hmm. Some of my fondest memories also related to this are the close collaboration with, I loved collaborating with speech. I loved collaborating with our dietary, with activities, and really advocating for experiences like that. If I'm thinking of 90% productivity and you're like, I need that 10% time for documentation, how do we make time for those special collaborations in our days? What's like the core, I guess, like business argument we need to make? And I'm going to piggyback another question on this because I can't help it. I just remember in this old payment model that was so driven by therapy, like therapists had, I don't want to say like status, but like a kind of a sway almost. Like I just remember being like, we're usually the person in the building with the highest level of education. Our time is really driving reimbursement. So then I think it was easier to be like, let's schedule things to go outside. How do we still do those special things in this different payment model?
Yeah, that can somewhat, be challenging if we only have 40 or 45 minutes or whatever, with the patient is how do we do those things? So I'll try and kind of address the first question and then kind of bring it back to that other one, that kind of collaboration piece and how do we do that? So as far as the first piece goes, right, that that can definitely be a challenge because instead of, I've got 75 minutes now with this patient. Again, I've got maybe half that time, sometimes even less. Obviously, anytime you're having a care conference, you're talking with the family, I do my best to have the patient there, unless it's something really, really sensitive, right? But in my opinion, that patient deserves, if we're talking about the patient, we're talking about the care, we're talking about next steps. Maybe they do need to go to long-term or in assisted living. Maybe they can go back home. I don't know. But anytime you can have the patient there with the family, the social worker or whatever, that can be billable time because that's so crucial. That's important. That's skilled, right? I hate to use the word creative. You just have to be smart with how you bill and document that time. But yeah, that's sometimes as much skill as anything else. Patient education, all those types of things, So anytime that you have your patient there, you can collaborate those types of things. That's good productivity, skillable time. The other thing that I often, talk with when I'm doing PRN with my nurses or CNAs have a question, say, hey, come on down to the gym. I've got the patient down there. Let's talk about that kind of in front of them. So I almost use like the therapy gym or wherever I'm at with the patient. That's my office. Sure, I don't want to be opposed to having open office hours. You can come talk to me before, after the day or whatever. I mean, that's fine. I'm clocked in. But yeah, if you see me with the patient, ask me the questions during that time. So that, again, they're kind of coming into our space and doing those things and having just that good, again, communication, collaboration, kind of what's going on in front of the patient. It's again, that's appropriate. Now, obviously, there's times we have to have a sense of, conversation. We have to even talk about the patient's family. Maybe you don't want them there. So that's where you have to carve out those 4 or 5 minutes. And I hate to say, do this during lunch or your breaks because we don't want to do that, right? We don't want to set up that norm. So yeah, the last step that I worked at, typically we would kind of have a kind of a quick huddle or meeting in the morning. And usually we'd have kind of 10 or 15 minutes in between our huddle to starting patient care where we just kind of have this quick, hey, let's kind of put together our schedule, let's reflect on some of these things. Our nurses and CNAs knew, hey, from 8:45 to 9, that's when we can go down and ask the therapist questions. Again, not that we want to be completely, standoffish per se, but it's like, yeah, come on down whenever you want, nurse, CNA, activities worker, family, but come on down to the gym. That's where you can find where I'm with my patients. So trying to kind of do all those things, at the same time versus just having a care conference for an hour during the middle of our day when I'm getting killed for productivity. Let's make that care conference part of their session.
Huh.
Yeah, kind of coming back to that second piece is as far as, therapists kind of being the owners in some ways of a nursing home or kind of being able to have whatever they want. In some ways, that's the great benefit of a skilled nursing facility. Every SNF will have a medical director who's a doctor. Usually those physicians come in once, maybe twice a week. They're reading charts. They're signing their name. They're prescribing. They're hardly looking at anything as far as patient care. They might go do some hands-on, quick patient evaluation for 5 or 10 minutes, but by and large, they're pretty hands-off. Nurses and CNAs, yeah, they're kind of more focused on medications and getting those things done on time and making sure the patient's fed. So when it comes to actual treatment and hands-on care and patient-driven care, therapists can kind of own and run that thing. So that's the beauty about a SNF. Is I've worked in multiple SNFs. I've probably been in over 200 different skilled nursing facilities throughout the country. I'm just through what I do, for my work as well as consulting practice on the side and some other things. And, honestly, I don't know that I've ever seen a SNF where the therapist is kind of told how to do their job as far as you must do this type of treatment and bill this way per se, like what you might sometimes see in an outpatient clinic. These types of codes bill higher, so we want you to promote to do these different things, or we have this really expensive equipment. You have to use diathermy on every other patient. It's those types of standardizations that you might sometimes see elsewhere. So again, back to your point, Sarah, for the most part, we can kind of run the ship and run the show.
Mm-hmm.
So I've loved that. Every stuff I've worked in, it's like I can do whatever I want. No one's questioning me. The only person that might question me is maybe another OT or PT kind of wonder why I'm doing that technique or whatever. But the amount of freedom you have to change a culture, to bring in what you want, to bring in your skill set, to have a positive attitude is totally out there compared to other settings where you're kind of put in this box of, hey, with the spinal cord injury in a hospital, here's what we do. In acute care, we go and reevaluate. We sit on the edge of the bed and we do bicep curls and leg kicks. For hands, here's the type of thing that we do and here's how we bill it. SNF, it's like, we don't really care what you do as long as you get your time with the patient. So it's like, sweet. So again, that can be good and bad. It seems like in SNFs, sometimes there's what I call a potato therapist that just kind of sits there and does the same thing every day. But then there's so many amazing therapists who are so creative and out there and spend so much awesome time with their patient doing all kinds of crazy, goofy, fun stuff. and no one cares or questions that. So that's the other benefit of a SNF is do whatever the heck you want as long as it's within reason and evidence based, but you don't have it, someone's sitting over your shoulder looking at your therapy. You might have someone sitting over your shoulder looking at how much time you're spending with them, but not the type of therapy or intervention that you're doing. So massive benefit to a SNF.
This is like solving a years-long mystery for me because I'm like, oh, I liked working in a SNF because it's a high autonomy place. And I loved being able to, or like one thing I remember being like, oh, we need a power wheelchair policy for this. And we just like wrote it quick. And I was like, if you're in a and we just made it. And if you're in a hospital, that's like a year of meetings. And it maybe doesn't get approved at the end. So I loved that autonomy there. I want to ask real quick, because I want to get to these questions too. So in 3 minutes, what are some hot topics that are just on your mind related to skilled nursing facilities?
And some of these we've addressed already. Like obviously there's the productivity theme. AOT has an entire section developed to skilled nursing facilities. They've got this really kind of cool productivity algorithm or chart. So if you're a member of AOTA, you can look at this. I've actually got it on my computer where it kind of says, okay, if we're looking at minutes, here's what's expected. Here's what you should be able to look at. Here's what's appropriate. So they give you a lot of guidance as well as some other journal articles about burnout and how to avoid those types of things when it comes to productivity. So that's always been a hot topic for nursing homes and probably always will be. But again, focus on what you can control. Yeah, I might have a productivity expectation that's 90%, but man, for that 90% of the time, I'm going to have some fun with my patients, and I'm going to do everything I can to get those good skilled minutes. But I've got a lot of flexibility and freedom with how I do this. Another big thing I think right now is with the switch to PDPM, it was so funny because September 30th of 2019, we didn't see a lot of groups happening in a therapy, setting in a SNF. Because if you saw 4 patients for an hour, you had to split up that time, 15 minutes for this patient, 15 minutes for this patient, so on and so forth. Suddenly, I would have business leaders always come to me and say, Trent, groups are bad. Look at this research article. You shouldn't be doing groups. Groups are this and that. Then October 1st, it was like, oh, groups are amazing. We want to start doing these things again. It was like, what changed overnight with the research? And really what it was just the payment model, right? So there are a lot of SNFs who, as far as concurrent or group time, you can spend about 20% of your time with a Medicare patient in groups. And so most companies are like, okay, Monday through Thursday is individual. On Friday, we put everyone in groups, groups of 2 to 6 or whatever. So that's a big hot topic right now because they don't really care how you do groups, but they just want these groups as big as possible. Of course, we know, Sarah, groups can only be beneficial if you kind of have individuals who can communicate or maybe somewhat, similar as far as function, versus a 40-year-old total knee patient with an 83-year-old cognitively delayed, patient who can't communicate. So that's kind of where we have to, it's okay to do groups. I get a lot of companies are kind of requiring groups, but again, you've got the freedom and flexibility to say, hey, maybe I do my group on Tuesday instead because I've got these 4 or 5 patients that are all appropriate. They're all actually discharging together. So I'm going to do kind of a quick little home modification discharge thing where we educate them. And so that's going to be my group for the week or whatever. So again, that's kind of a hot topic right now because a lot of SNFs are kind of forcing these groups. Continuing education, I would say, is another big thing. And this is near and dear to my heart as well as yours, Sarah. A lot of SNFs, like a lot of hospitals or outpatient settings will give you like a budget for $1,000 or $1,500 or whatever. When it comes to SNFs, most SNFs will say, yeah, we will provide your continuing education, but they'll give you like a $50, a $100 subscription to, a group out there. And sometimes those are okay, but sometimes that limits you, right? So make sure up front that you ask your company and say, hey, do I have some flexibility with my continuing education? I can take care of my ethics virtually. I can take care of these other things virtually, but do I have some hands-on, can you give me $1,000 where I can go take a hands-on course or do something that might be a little bit more expensive, but it's going to improve my skill and make me a better treating therapist so that I can maximize my productivity. The more skill I have, the less productivity, in my opinion, becomes an issue because I've got so much to do, right? That I'll never run out of time or ideas per se. So just think about that piece as well. Is to me that's very important. If your company is willing to invest in you, they care about you and their patients. The last, I think, hot topic button right now is just kind of the business side of SNFs. It seems like every single week or month, I see a big article that, hey, this massive company, this, private investment firm bought this group of skilled nursing facilities. So now they own 400 nursing facilities or this group now, private investing firm bought this, so it's becoming more and more of kind of a business model. I think people are smart, right? When it comes to finances, we don't typically work with dumb people. They're smart. They're making investments into the future. As our patient populations, our baby boomers continue to get older, SNFs are kind of becoming, in the last 4 or 5 years, we've actually seen an uptick in skilled nursing facility overall census and occupancy. It dropped during COVID, but really, again, the last few years, that started to march up. Here in the state of Utah, for example, we're about 66% of all of our beds are filled. 10 years ago, that might have been 45 or 50%. So we're seeing more and more people occupying SNFs, as well as just kind of the culture in the United States of America. We have fewer, kind of multi-generational homes. So what happens when mom and dad get sick? It's like, well, both me and my wife work, all my kids are busy in college, off to a SNF they go. Whereas before, in the past, you might kind of have them move in with you or one of your siblings or whatever. And so that's kind of going away. And so because of that, these businesses are seeing this is a growing market. So we're seeing a lot of these private equity companies who are trying to go in there, right? Cut as much as they can and then resell 3 or 4 years later. So there's opportunity with that as far as more resources and bonuses and those types of things. There's also, when it becomes more of a business, it might be less about the care and kind of more about how profitable can I become. Again, that might be the same for outpatient clinics or other home health companies even, but we are especially seeing that in SNFs where it's becoming much more of a business model. This private equity is coming in and buying, snatching these things up in droves, essentially. So just be aware of that, be aware of what company that you work for. And is this a national company, more of a local company? Who are they owned by? Is it really owned by this managing group, or is it owned by this, giant conglomeration of owners in New York or whatever? So just be aware of that.
Yeah. You had sent some slides that we're going to pull up too, I think related to this just like changing nature of SNFs. Like I was working in one that was like county owned, pretty dumpy, but they are looking nicer. We have these slides going that show like a nice foyer and grand piano and just like very different than what I was working in. I don't want to put words in your mouth, but do you think part of the implication of this is like we might be seeing nicer facilities, but we really need to be sharpening our skills at making the business model or the like business argument for some of our services, because that private equity ownership just has a different mindset than like my county ownership would have.
Totally. Yeah, that's such a great point. I know we don't have a whole lot of time because we want to get some questions, but yeah, for those of you watching this, we're going through a couple of slides, and these are actually nursing facilities where I work at here in Utah as far as doing my quality stuff, right? So as these private firms come in, it becomes more of a business. The good thing about business is, of course, it's competition usually, right? So it's like this skilled nursing facility was kind of old and dumpy. Suddenly a new one comes into town, and it's like, okay, well, in order for us to compete, our private equity is going to now invest $6 million to kind of build this new facility, right? So in some ways, we're actually seeing more and more facilities invest because they have to as it becomes a business. But you're right, Sarah, as it becomes a business and they're trying to make it all shiny and new, that doesn't necessarily mean that the care is going to be any better. So that's where we come in. It's like, yeah, I love shiny and new. I love this new ADL kitchen. In fact, in this very facility that I'm showing you, it was funny because we went and toured that facility. Like, Trent, we know you're an OT. Check out this brand new ADL kitchen. This facility has been open for 6 months. They still had stickers on the refrigerator and the stove. They had not used it at all. I was like, you dropped 30 grand or whatever into this nice ADL kitchen. You don't even use it. So that. I'm not saying that was bad on the owners. That was bad on the therapist for having something nice and shiny new, but they weren't even utilizing it, right? So it's not, you mentioned county owned and some are, but again, as these private equity firms come in, we're seeing more and more facilities becoming more like a business. So they're trying to compete and upgrade and do some nice things. And so sometimes it can actually be a really cool environment to work. And that, I talked before about getting outside of the gym. I mean, the slide deck really showing you, all kinds of different areas where you can go and spend time with your patients. This particular facility, right? Laundry area. You can see my gal on the right doing some IADL care. She's actually cleaning up dog messes as she prepares to go home, right? So it's just a matter of utilizing these spaces. The picture here on the left, I mentioned before, she's at Walmart. This is one of our sessions. The same gal on the right? Before we went to Walmart, she got to be able to get her socks and shoes on, So each of these things kind of leads to another. But again, in SNF, I've got all this flexibility to do these types of things.
Mm-hmm. Oh, truly writing your notes in a skilled nursing facility is so easy because there's so many functional things to do.
Totally.
As a final question, and this is going to segue a little bit into some of the resources that we have related to SNFs. We got a question about long and short-term goals. I do think I have a documentation example from a SNF on OT potential. Trent, could you and I connect later and could I run it by you maybe? And
yes,
you
please.
could. But what I wanted to ask about long and short-term goals, they're so similar to your other adult rehab settings from, you're the expert, I don't want to put words in your mouth, but a question that I would have is just that time frame. And I'm trying to remember like how long a SNF length of time usually is. And when you're thinking of long-term goals, what are your advice for just that time frame that you should typically be thinking when you're writing that long-term goal?
Yeah, very fair question, right? So most patients, like typically Medicare, if they're on standard Medicare, sometimes with Med Advantage and other things, it's not exactly the same, but usually they'll have about 20 days that's 100% covered for. So it's funny because you'll see a lot of SNFs, hey, the average patient that comes in, they're out in 20 days. Well, there's a payment piece behind that because anything beyond 20 days, then suddenly they're paying, out of pocket 15 or 20% or whatever plan that they have. So typically your long-term goals in a SNF will be usually about 3 weeks, right? So usually that makes my short-term goals probably a week and a half, something like that. But it's pretty amazing what you can accomplish in 3 weeks if you're seeing these patients every day and if you're truly doing what we're supposed to be doing and getting them out of the room and out of the, gyms, things like that. But what's also great about that versus outpatient other places is usually we're seeing these patients every single day, right? So just with the amount of volume and time and all those types of things, yeah, there's a lot that you can do. But typically for most of my short-term Medicare patients, it's going to be 3 weeks. So maybe if they're non-weight bearing or something like that, it might go to 4 or 5 or 6 weeks, or on some type of expensive medication, maybe it extends beyond that. But usually 3 weeks is going to be my long-term goal.
I loved skilled nursing. And before this conversation, I love it even more. Now I realize why I love it. We're going to have resources for people. We have a public-facing post on skilled nursing facilities that will have just a lot of these, like the basic information about it. I am pretty sure we have an example note. If we don't, I will get one and we will have that in the club. I'll run it by Trent. So we get the thumbs up on it. Trent, thank you so much for just this time today. I loved it so much. Is there a final thought that you want to leave us on related to skilled nursing?
Growing up, I still remember as a young Boy Scout being dragged into a skilled nursing facility to sing holiday songs,
yes.
going, oh, this place, who would ever work here? And then, 30 years later, I'm there. Skilled nursing facilities aren't this decrepit, depressing, urine smelling place that sometimes we think they are. Hospitals can sometimes be that, long-term care centers can sometimes be that. I've seen outpatient clinics where people have had messes, it doesn't matter where you go. We're working with human beings who are going to have issues and accidents and all those types of things. And so don't shy away from a SNF just because it seems like the lowest level of care. I have to actually provide way more skill and thought into my plan of care in a SNF than I have to in a hospital or outpatient where sometimes things are just kind of, laid out for me. It requires a lot more depth and perspective to make it work for this patient than it can in some of those other settings. So don't ever let you think you're less skilled. It's so creative and mind thinking and cognitively rewarding to take those patients that might be a little frail and make something work versus work with an athlete or someone in a hospital who's gone home in 2 days.
Mm-hmm. Yep. If you love relationship or that relational piece of therapy and autonomy, get yourself to a SNF because they are awesome. Trent, this was so fun. I hope to have you back as a guest someday because I just want to keep talking about so many topics related to this. So thank you so much, though, for your time today, for all that you shared with us. It's just been a real pleasure.
Thank you so much for having me on.
Thank you for joining us on the OT Potential Podcast. To earn 1 hour of AOTA-approved continuing education for your time today, you will need to sign in or sign up at otpotential.com. Once you're in the OT Potential Club, you will find a 5-question post-course quiz connected to this episode. When you pass the quiz with a score of 75% or higher, you will be able to download a PDF certificate that certifies your completion of this course. Okay, I want to thank you for joining us today, and we'll see you next time.